Hello, everyone, and welcome. Thank you for joining us for today's webinar, Reducing Readmissions, Top 5 Ways to Incorporate Help at Home, presented by Home Instead and hosted by the American Society on Aging. We will begin shortly, but before we do, a few housekeeping notes. I would like to direct you to the left side of your screen where you will see 5 tabs labeled Speaker Bio, Important Information on Group Viewing, CE Application Here, FAQ/Troubleshoot, and Event Resources. The slides for today's presentation are available for download under the tab labeled Event Resources. You will find information on how to claim CE credits for this event under the CE Application Here tab, including links to the application and to the step-by-step CE guidance webpage. Please review before submitting an application. Also, please be aware that your time is logged and you must view the entire hour-long webinar to be eligible for CE credit and access the application. You will be able to access the CE application a minimum of 2 hours after viewing the event once attendance syncs with the application platform, although it may take a little longer, so we appreciate your patience. If you are not logged into the webinar directly using the email address you registered with, then you will not be eligible for CE credit as we have no way of tracking your online attendance. If you registered before the live webinar, you will also receive a follow-up email by the end of the business day that will direct you on how to claim CEs and include links to today's slides and recording. You have 60 days from the live event date to complete a continuing education application. If you have any questions during today's presentation regarding the webinar, you can send those to us at any time using the Ask a Question box, and we will do our best to get to those questions in the last few minutes of today's programming. And now I'd like to pass it over to our moderator for today, Dr. Lakeland Eichenberger, who is a gerontologist and caregiver advocate at Home Instead. Lakeland?
Thank you so much, Victoria. Hi, everyone. Welcome to today's webinar. Happy Wednesday. We're so grateful that you have joined us for this important topic. Readmissions is always, I think, an important topic that we want to find ways to reduce readmissions, and so I'm really excited today for our guest presenter, Ruth, to share more about this topic. She really has great expertise in this area. So to get us started, I would love to just introduce her and read to you her bio. It's pretty impressive. So Ruth Lupa has over 2 decades of experience as a registered nurse and has honed her expertise in skilled home health care and home care, all stemming from her initial experience from leadership positions in post-acute care settings, including a director of nursing and a manager of clinical practice. Her experience in these roles have brought her to taking the lead on many patient care initiatives, including quality assurance, performance improvement, infection control, OASIS reviewing and coding, and direct patient care to support her field staff, all of which provided her with insights required to better educate, support, and mentor field clinicians, which further elevated the quality of care and significantly reduced the risk of rehospitalizations, hence making her a great speaker for today. In 2020, Ruth transitioned to a new endeavor in home care with Home Instead. She's undertaking a comprehensive assessment, care planning, and training of care professionals role, and she provides much-needed support to families and other agencies by collaborating with our services at Home Instead. In addition, she mentors other Home Instead RNs, especially in the intricate regulatory landscape in the state of Minnesota, which is where she is based in her practice. Ruth's dedication extends beyond her primary responsibilities, including being an advocate for the well-being and higher quality of care of vulnerable adults. And she holds the position of vice chair in her local senior advisory board and volunteers her time at senior and community events. So Ruth, welcome. Thank you so much for being here, and I'll pass it over to you.
Thank you, Lakeland. I appreciate that. Good afternoon and welcome. Anyone working in healthcare today knows the importance of reducing hospital readmissions or rehabilitation facility readmissions. Patients are at risk for readmissions if they lack that proper support at home. The days following the transition back to home can be crucial to keeping the older adult safe. However, older adults and their families may not be fully prepared for all that's involved in the person's care as they adjust to their home environment. And I am so grateful to have you all with us today to learn how to support and how support and help at home can be so crucial to a successful transition. Participants in this webinar will be able to understand the common reasons older adults can be readmitted, realize the top 5 ways help at home can reduce the risk for readmissions, learn tips for family caregivers to prepare the environment for their return home, and discover resources to support older adults in the home. So let's get started. There are several considerations for older patients, many of which can put them at risk for readmissions or pose challenges with compliance after returning home. First is that older adults are the largest consumers of healthcare in the U.S. People age 55 and over account for over half of total health spending. Therefore, this transition from hospital or inpatient facility to home is fairly common. Changes or limits in physical and cognitive levels of functioning could impact their transition home from the hospital too. We also have to be mindful of recent history of frequent healthcare visits and interactions. There's oftentimes we use the term frequent flyers, or those who return to the hospital, clinic, ER, urgent care regularly. Older adults may be experiencing instability with comorbidities, which could complicate a return home or cause a readmission. Some examples are challenges with managing their diabetes or heart failure, dementia, for example. Multiple medications are common among older adults, and this can increase the risk of medication mismanagement. We will talk more about that later, though. We also know that older adults may need assistance with their activities of daily living, also referred to as ADLs, such as walking, transferring, eating, dressing, and grooming. This could be either temporarily after returning home, or it could be on an ongoing long-term basis. Family may or may not be available or may not feel comfortable assisting with some of those activities of daily living. Their ability to do instrumental activities of daily living, or IADLs, can also be impacted, and some examples of these are using the phone, a telephone, a cell phone, a landline, shopping, preparing meals, housekeeping, using transportation, taking their medications, and managing their finances. And there could also be treatments and wound care involved. Family support may or may not be available to the older adult depending on the proximity or their availability. For older adults that live alone, there may need to be additional considerations for their safety and security after a return home, especially in regards to their living environment. And finally, the healthcare system is complex, and older adults may need assistance navigating their healthcare system. We also need to consider additional factors. If we take a holistic approach, we need to consider the cognitive, behavioral, functional, and social aspects that can put an older adult at risk for readmission or create some challenges during a return home from the hospital. When considering the area of cognition, we may commonly see confusion, and there's a variety of reasons such as delirium, often post-hospitalization delirium. Sleep deprivation is another big one. Other cognitive issues could be related to Alzheimer's disease or other types of dementia. Behavioral issues can also arise, such as anger, irritability, agitation, and sadness, which can be symptoms related to cognitive issues, but also be related to that loss of independence and resulting from their medical issue or their decline in condition. Functioning is something else to be aware of. Perhaps their physical function is limited temporarily or permanently. They may also experience sensory limitations and pain. From a social standpoint, it's important to consider their support network. I mentioned earlier that they may or may not have family available and willing to assist, and they may lack the resources or be limited in their knowledge of those resources. They can be isolated, especially if they live alone, which research is showing can be hazardous to the health of an older adult and can be problematic upon a transition from hospital to home or inpatient facility to home as well. Finally, depression can occur, which can also cause an older adult to withdraw socially. It could also impact their appetite, their attitude towards recovery, and so much more. You'll notice that many of these factors can also impact their compliance with their new regimen, and of course, this is going to significantly impact their risk for readmission. These various considerations and factors on this slide and the last slide make the transition home and readmission complex. As we all know, readmissions are a hot topic, especially reducing these readmissions. So why do so many patients go back to the hospital within 30 days of being discharged? Well, there isn't just one answer because not all readmissions are avoidable. Some people go back in for a scheduled treatment. Some are too weak when they're first admitted, which might mean that they were unable to have all the treatments that they needed, so they have to go back for what they didn't get done the first time. Others are discharged for one condition or illness, go home, and then have something new or crop up or have an accident. To give you an example, I had a client that was discharged after having shoulder surgery, so outpatient. It was inpatient for her medical conditions, but she was readmitted 2 weeks later when she had an exacerbation of her heart failure, and they truly were unrelated. So as you can see, not all readmissions are avoidable, but many are. So let's take a look at some drivers of avoidable readmissions on the next slide. The information I'm about to share comes from a 2013 Robert Wood Johnson Foundation report called The Revolving Door, a report on U.S. hospital readmissions. It's an analysis of Medicare data by the Dartmouth Atlas Project and stories from patients and healthcare providers by Periundum Research and Communication. Now, I realize this report is from 2013, but it still contains great information that's still super relevant, and I'll acknowledge that some health systems have found solutions to these various drivers of readmissions over the recent years. Some, however, are still challenged by them. From the provider perspective, drivers of readmission include discharge decisions that are complicated. Certain reasons for hospitalizations have higher readmission rates than others, which may impact the discharge decisions and how long the patient stays in the hospital. Some providers still feel pressure to discharge quickly when it's not always in the patient's best interest. Lack of clarity regarding who's responsible. For older adults, there can often be many providers involved, which can cause communication challenges. Patient's family can push for discharge. Oftentimes, patients just want to go home and think they'll be fine to manage on their own at home. Communication issues in coordinating and planning for post-discharge care. This can occur between providers, family, and the patients themselves, and even the care community or rehab setting. Patients are not always honest. They're not always truthful about their home situation and their living environment and the help that they might or might not have. This can be due to privacy or embarrassment about the lack of resources. Patients may not have the means to meet their basic needs, and this is another big issue. They need assistance finding resources to help meet their needs post-discharge. Now, from the patient's perspective, many patients felt they were discharged too soon. Some felt the timing of their discharge was motivated by the hospital's financial considerations. Some patients, however, wanted to be discharged and did not resist, even though they still felt too ill to be at home. Many didn't understand their discharge instructions. They felt tired, afraid, out of their element in the hospital. 15 minutes of care instruction and pamphlets about their illness just didn't seem to be enough, nor could they remember all of it. Care instructions were too general. In some cases, discharge instructions lacked the detail patients and caregivers needed once home. They were hoping for more specific instructions about what they should eat, what they should avoid, details on how to clean an incision, how to inject their insulin, and what the risks were if they stopped certain medications. Patients and caregivers wished they had been more assertive. They often felt like they should have asked more questions. It's found that having a family member or other caregiver present during discharge made a significant difference. Patients also wished they had been more aggressive in asking questions and pushing for details they clearly needed after their return home. New diagnoses posed special challenges. A new diagnosis can be so overwhelming, and patients often want more information and more one-on-one time with their doctor or their primary provider, more hands-on training about their new condition and how to manage it and all the follow-up care. Primary care physicians were missing from the picture. In a number of cases, patients actually left the hospital and were not even seen by their primary care physician or their regular specialist. Some had only limited or no support once home. Single or divorced individuals who returned home alone were too weak to care for themselves. Some weren't ready to change behaviors. 2 patients admitted had reported that they didn't comply with their care instructions once they left the hospital, and then engaged in behaviors that put their health at risk and perhaps triggered the readmission. A number of patients had been battling their chronic conditions for years, illnesses like diabetes and heart disease, and yet lacked information about how to care for their conditions. If they did not receive this information during their initial hospital stay, then they went back to their unhealthy behaviors once they were home, and therefore it increased their risk of readmissions. If their doctor was affiliated with the hospital, outcomes were likely to be better. When there was not this affiliation, some patients were confused about follow-up care and who to go to for what and when, and became sick again at home. Some final readmission drivers for consideration. The revolving door report that I referenced earlier has identified some of the reasons for avoidable readmissions. Patients with chronic conditions may pose a particular challenge. It's important for the hospital not to assume the patient already understands their disease process and how to care for their condition or conditions. Making sure that they have a good understanding can definitely help decrease the risk of readmission. And think about it, a lot of times the patients are there because they're acutely ill. They have pain. They're having medication changes and side effects and adjustments and treatments that they're not used to. And it's overwhelming, and they're not getting good sleep. So those are all factors that are impacting them. Communication issues with patients and families. Communication is key to understanding the discharge plan. It's important to identify the primary family caregiver for the patient. What this does is help streamline that communication. There's a go-to person. There's that main person that patient can count on. Reconciliation of medications. It is important that the older adult has a really good understanding of new medications, medications to stop taking, and changed medications, changed doses. A medication reconciliation can definitely help reduce confusion. Coordination with community clinicians and non-acute care facilities. Earlier, I had mentioned that older adults can get confused by who to see for follow-up. Make sure that's really clear. There could be a lot of community involvement as far as whether they have other support like that they're referred to, such as home health, home care, hospice, etc. The availability of longitudinal post-hospital care. Some communities may have waiting lists for post-acute care. Ensure families know that their options to help with their decision making. Finally, family members or caregivers may be left out of the discharge planning. This can create communication issues and could impact the compliance with the discharge plan. So always try to include family or primary caregivers in this process as often as possible. We have talked a lot about readmissions. Let's talk briefly about the Hospital Readmission Reduction Program. When older patients return home from the hospital or inpatient facility, it's the little things that often get overlooked. The older adult is sent home with detailed discharge plans containing important information and instructions for the patient and their family members. However, families may not anticipate the additional tasks that will be required to help making their aging loved one's transition home a smooth one. So planning ahead is vital. And when considering the assistance an older adult may need after being hospitalized, there are 4 key activity areas that may require family caregivers to assume more responsibility, time, and effort than normal day-to-day activities. Many of these activities may also be delegated to home care's trained professionals or home health care services. Healthcare tasks such as checking their blood pressure or blood sugar and reminding to do treatments and exercises. Medication management, for example, setting up meds correctly, the right dose, times, etc. Household management, like getting rid of throw rugs, clearing pathways, adding grab bars. Family communication is so that everyone can assist in the care for the patient. You want them to all be on the same page with the needs. So let's take a closer look at these healthcare tasks. This support system is crucial for the success of the transition and the prevention of readmission. When considering support in the home, it's important to determine for how long is support needed. Is it a few days, weeks, indefinitely? It's also important to determine when is care most important. Is it days, evenings, overnights? Which one is the most difficult for the client, the patient, older adult? I would find that my clients have benefited from round-the-clock, sorry about that, from around-the-clock care the first few days or weeks home from the hospital. Once they're able to regain some strength and get back into a routine, understand their meds better, and that schedule's modified to decrease the amount of hours they might need. It's also important to determine if family is able to help. They may not be available due to their distance or work or other obligations, or their own health issues is another factor. It may be that other support services are needed. 2 of the most common supports recommended for a return home is home health and home care. Home health care is often a service paid for by Medicare when a patient returns home. This is a short-term service. Home care is another means of support, but is not covered by Medicare. It's primarily self-pay or sometimes covered by long-term care insurance. So let's talk a little bit more about family caregiver support. If family members can communicate effectively with providers, their loved one and among other family members, it can definitely help with a smooth transition home. Some of the things to consider would be preparation of an emergency and medical contact list, maintaining that list with current information. They should also communicate frequently with family members and their healthcare team. They can help with paper correspondence, such as paying bills and assisting with mail. If the family takes turns providing care or a professional caregiver is brought in, It is important to provide instructions and training to those individuals to help with discharge plan compliance and safety. Finally, family can assist with assembling and storing of important documents such as advance directives, living will, or standard will. So now let's talk a little bit about home health care. Home health care focuses mainly on medically necessary care for rehabilitation, education to patient or family designee to work with the patient to make progress towards goals. This type of care is ordered by the doctor and it can include nursing, physical therapy, occupational therapy, and or speech therapy, possibly a home health aide, and possibly a medical social worker. Depends on the needs. Home health care providers are, like I said earlier, usually covered by Medicare, but are Medicare certified and it's considered short-term intermittent care. The duration of a typical visit can be anywhere from 30 minutes to an hour. Some role examples are they all have to do skilled assessments. They do post-op rehabilitation, mobility training, wound care, education on medications and disease management, pain management, IV therapy, injections, and this, again, is typically covered by Medicare, but can also be covered by Medicare Advantage plans, Medicaid, private insurance, and VA insurers such as TRICARE. Now, let's look at how this compares to home care. Home care focuses on support for cognitive and behavioral and functional and social factors. This type of care is provided by home care aides or trained professional caregivers. This type of care can reinforce many aspects of a plan of care and can cover a lot longer duration than home health care. Anywhere from a few hours a day to 24/7 or even a live-in position. Home care is like an extended family member that typically would help out and are the eyes and ears in the home and on the patient. And it's definitely helpful in absence of a family caregiver that their time is limited or they're just not a willing participant in the plan of care. Agency employed home care professionals are provided specialized training to meet the needs of the older adult. And some examples of the type of care that can be provided by home care are safety assessments, reinforcing plan of care compliance, medication, exercise reminders, nutrition, hydration, socialization, toileting, bathing, continence, dressing and grooming, transportation, respite care for family members or family caregivers, Alzheimer's and dementia care, and support for patients on hospice. These are all important things in order to keep a patient out of the hospital or out of an inpatient facility and keep them safe at home. The question is, how is this paid for? Well, oftentimes it's private pay or family funded, sometimes most of the time covered by long-term care insurance, veterans benefit assistance, and sometimes a Medicare Advantage plan or Medicaid waiver. The biggest point is that there is support for patients and their families. Let's get into a bit more detail about home care, how home care can help in making a difference in reducing readmissions. Family members are often overwhelmed by the wide range of caregiving responsibilities that are listed. This can be due to a lack of time in their busy schedules. And we've kind of already touched on this a little bit, but lack of confidence in their caregiving skills or the inability to provide for these needs. This can unfortunately result in missed follow-up appointments, medication mismanagement, and readmissions to the hospital. It's really important for family members to review the discharge plan or care plan and ask questions. As professionals, We need to encourage them that there is no such thing as a silly question to ensure that they feel comfortable asking those questions. Family members are integral to care coordination, and this is very important for safe and effective care and communication with all of the client's care team. This can include home health, home care, medical providers, specialists, etc. We know that vital signs are important to monitor after a hospitalization, especially for certain conditions or medication changes. We need to make sure families know acceptable ranges for those vital signs and what is considered a red flag, and most importantly, who to contact when the vital signs are of concern. Many family members do not have a medical background, so we need to ensure that they understand how to operate or adjust medical equipment. Some family members may or may not be comfortable with assisting with personal hygiene. We want to provide resources or suggest trained professional caregivers to assist if needed. Family members can be key to ensuring follow-up care. They help with scheduling, transporting their loved one, taking notes during follow-up, and giving the provider additional information that their loved one may leave out. Have you ever heard when a client will say that, or the family member will say about their loved one, well, they're just showing off for you. So a lot of times when they go to their appointments, they're not necessarily fully honest, or they put their best foot forward. They can also help to maintain the schedule of healthcare visits and appointments. The next area, big one, is medication management. Medication, as many of us know, play a big role in readmissions, as medication changes or new prescriptions can be very confusing. Patients may also inadvertently discontinue important medications needed to stay well. Others may not have the right prescriptions or be able to fill them. Some stop the medication due to side effects or advice from someone else. To improve compliance, family members can help with the following. Order and pick up prescriptions and refills, ideally before their loved one returns home. Help with medication compliance by giving reminders. Fully understand the labels and instructions, directions, and knowing to look at expiration dates and help their loved one understand as well. Administer correct medications at the right time, the right amount, the right dose. Monitor for side effects and contact the provider or pharmacy if there's red flags. Store medications properly and safely. I mean, some can be refrigerated. Some need to be in a cool place. A lot of people keep medications in bathrooms, and that's a humid environment, and it's not necessarily good. Maintain medication schedule. A medication management system may also help, like a pill box, an automatic dispenser, or pre-packaged medications that are filled by the pharmacy. How to dispose of medications properly? Use of medication tracking system to record all medications, like pain medications, and tracking what did you give and when, and how often are you supposed to give it. There are things around the house that also have to be managed. Arrangements need to be made for transporting the client to all their follow-up appointments. This can include a primary provider, specialty doctors, therapy appointments if they're going to outpatient, pharmacy, pick up prescriptions. A big part of the arrangements for these appointments are having someone sit through the appointments and take those notes and report back to a designated family member and help the client follow up and follow through. There is another key role for help in the home. Following a hospitalization, there's often a recommended diet that can be vital for health and healing. Some important factors with following a nutrition and hydration plan include help in buying groceries, keeping the kitchen stocked with appropriate food choices, meal preparation, meal adaptations, based on specialized diets or limiting or limitations that they might have to have or restrictions, encouragement or monitoring of hydration. There is a lot to manage for a newly discharged person, but let's talk about one more. Household management. Oftentimes, the older adult has been away from home for several days, weeks, even months. There are several things that families can do to help with household management. Of course, ensure a safe environment, completing frequent home safety checks, making sure pathways are clear, grab bars are installed if needed, and that adaptive equipment is obtained, preferably before they actually get home from the hospital or inpatient setting. Check their refrigerator for outdated and spoiled foods before they actually get home. It's really important because food poisoning can put them right back in again too. And it's not a comfortable position to be in for that older adult if they have food poisoning on top of all their other medical conditions. I think a lot of people forget about their refrigerator and returning home to that. Preparing special meals such as a low sodium or liquid only diet, shopping for what's needed upon return home, those special foods, maybe some new supplies. Managing their schedule and communicating with visiting home health or home care professionals. If home care is brought in, family can help coordinate the schedule. Arrange for deliveries of medical supplies and equipment. Steps to take when preparing for your older adult to return home can be overwhelming. And Home Instead has done a great job at creating a tool that can help break the transition into steps and tools. In this guide, Returning Home, you will have a comprehensive tool on how to help an older adult transition home from an inpatient stay. It starts by looking at steps family members can take before leaving the hospital. Then, the first few hours and days, and finally, the next 30 days after discharge. It breaks it all down for you. The link in the PowerPoint will take you to this free guide. So let's talk about questions to ask before leaving the hospital. Planning for a smooth transition back home can begin as soon as the person enters the hospital. Getting prepared begins with asking a lot of questions to the medical team and the patient and their family. Instead of listing out specific questions to ask, I group them into topics that patients and their families will want to address. The length of stay and extent of illness. What the patient will or won't be able to do post-hospitalization. Dietary or nutrition concerns. Medication and medical equipment needed. Follow-up care required. Warning signs specific to their condition. What kinds of help will be needed, both for the short term and the long term? Inquire about insurance coverage and the financial considerations to ensure that they can obtain what's actually being prescribed, whether it's medication or new equipment. They will also need to know where to find those resources needed to meet the discharge plan. It's important to prepare the home before the patient returns. Let's talk about that on the next slide. Once some of their questions have been answered, they can begin to make all of the necessary preparations, such as purchasing the medical equipment, having it delivered, checking with the pharmacy about medications and making sure they're available in the home the day of discharge. Make safety improvements to the home prior to discharge. Again, adding grab bars, removing throw rugs, installing a permanent or temporary ramp, for example. Arranging for rides to follow-up medical appointments and therapy visits. Another task that often gets overlooked is, again, we talked a little bit about it, the cleaning up the refrigerator, but also making sure to stock up on healthy food and changing the bed linens, especially if they've been away from home for a while. It's these little things that really can make a big difference for a smooth transition. Home Instead, in their booklet, the one called Returning Home, that was shown a couple of slides ago, that also includes a discharge checklist. And I thought you might find it helpful when working with patients or your loved ones. So let's take a look at that on the next slide. This booklet, again, can be downloaded for free directly from the PowerPoint. I won't go through this line by line, but you can see how comprehensive it is. Families can check these boxes off as they complete each item on the list. If we look at the next slide, we can see that it continues. These seem like simple things and seems like I'm stating the obvious, but if you've ever been in a crisis situation or under a lot of pressure, you can tend to forget to ask those specific questions or certain questions and fail to get the right information. This checklist and the Returning Home Guide can help families and professionals check to make sure all information is anticipated and communicated. Let's see what to look for when the patient finally gets home. The first few hours and days back at home are most critical. This is when watching for warning signs is so important to ensure that their medical condition is under control. It's also a good idea to keep a daily record of medications taken, meals eaten, activities undertaken, and assistance provided. We'll look at those warning signs in just a few moments. For caregivers, it's important during the first 30 days to make sure the patient keeps all follow-up doctor appointments, rehab appointments, and that their healthy foods are available, medications are picked up and at the home, and that the discharge instructions and any teaching materials are available for them to review. In addition to checking progress, these appointments are critical for any necessary prescription updates, blood tests to reveal hidden issues, proper incision and wound care, follow-up x-rays and CT scans that help ensure that everything is going on the right track. Another common concern for patients and their family caregivers is getting transportation to these appointments. Older adults may need to ask other family members, friends, local service agencies, or home care providers to help out. Now let's take a look at those warning signs that we just talked about, or that I mentioned. During the first few days after returning home, it is especially important to watch for some warning signs. And there are some more general problems that would warrant a call to the primary medical provider, such as no bowel movement in 3 days, new skin problems, change in balance, coordination, or strength, change in mental status or behavior, ineffective pain management, nausea, vomiting, diarrhea, medication issues or dizziness, fever. Signs that require a call to 911, a fall with bleeding or broken bone, especially if they're on a blood thinner such as aspirin or Eliquis or Xarelto or Coumadin, warfarin. Severe or prolonged bleeding, again, related to those medications I just mentioned. If they're on those in addition to prolonged bleeding, that can be a significant issue. Severe or prolonged pain. You're unable to wake up the older adult. New onset of slurred speech. Sudden weakness. Chest pain that medication does not help resolve, or increased difficulty breathing. But we have more additional resources. These tools can be downloaded from the PowerPoint, all for free, but can also easily be found at returninghome.com. Again, we have the Returning Home PDF link, the Home Safety Checklist, and the Action Plan for Successful Aging. This one has a plan for the what ifs, and for those that have a major health event that change the trajectory of their life or significantly impacts their day-to-day actions. And some more links and resources. Each of these links have user-friendly and easy-to-follow interfaces. They will help connect you with a wide range of tools, educational resources, and caregiving support. Definitely check them out. I know this is a lot of information, but you'll definitely be able to refer back to this PowerPoint and some of the key points that I gave. I want to thank the American Society on Aging and all of you for your time today. Lakeland and I will take a moment to take any questions that you might have.
Thank you so much, Ruth. What a great presentation. All such wonderful information that's helpful for patients, for their families, for professionals on things to consider when returning home to hopefully avoid those readmissions. So just want to thank you again so much for your insights. And it looks like we have some good questions coming in. So if you're ready, Ruth, we'll kind of start to tackle some of them.
All right.
Awesome. One of the questions was, what about pharmacists? How can they be a support to older adults and their families in kind of this discharge process? I know I have on my podcast, Caregiver Chats, I talk about how sometimes pharmacists are kind of the best kept secret because they're very accessible to the public. You go to your local pharmacy like a Walgreens or CVS, or you go to your grocery store that has a pharmacy and you can walk right up and talk to your pharmacist. So Ruth, how have you seen the pharmacist play a key role kind of in this whole discussion around readmissions?
That is a fantastic question. They are fantastic resources. Definitely can be utilized for that medication reconciliation that I mentioned. They can give patient-friendly or health professional printouts and information about the medications and any potential interactions, whether they're minor or major. Definitely can help give some considerations, especially if there's a need for lab values that should be checked that can pose an opportunity for the older adult or their caregiver to bring that to their next doctor appointment so that they can be more informed about things that they're going to want to have checked on. The pharmacists can also help navigate considerations when there's a possible side effect or interaction that they're not sure whether it's normal or something to be worried about, or if it might warrant a call, or should it be a 911 thing. The last thing I can think of off the top of my head is they can also help to, in that reconciliation process, they can help to make sure there's no duplications of medications or help educate them on that. But even more, they might have the capability to have a system in place or recommend a system in order to make taking their medications more, to keep them more in compliance with it. If it's maybe they can refer them to a medication alarming system that will actually beep at them when it's time to take them, or they can pre-package them in little packets so that they don't have to think about what bottles to open, or maybe they have vision deficits that they may have interventions within their pharmacy or can recommend products that can help, expedite safe medication administration.
Those are all great points, Ruth. I agree. There's so many ways that pharmacists can help. So that was a great question. I'm so glad that somebody brought it up. And also, I know, sometimes there's alternative methods of various medications if someone is having difficulty, so they can talk with the pharmacist about those options and then, circle back with their primary care provider. So such, again, a great resource for families and patients, and so hopefully people will utilize them. So great question. Another question, someone's asking about tips for dealing with resistance. They're saying, patients who are discharged home, they refuse help at home, even if they have the means and access to quality care. And Ruth, I don't know about you, but when I was a client care coordinator in the franchise in my local city, I would, hear these, older adults being resistant to care. They didn't want somebody in the home. So have you come across that in the client base that you have worked with, and maybe some tips or advice on how to overcome this resistance that we sometimes are met with?
Great. Another great question. Yes, I have dealt with this many times and get lots of calls from either care professionals and even in previous home health skilled setting on how to deal with that. And well, first of all, we don't want to force anybody to do anything that they don't want. But a very important intervention for this would be to know a little bit about the person before even going into the home and understanding a little bit about them, their even previous employment or occupation can help, or how many children they have, and how you make that first impression as a caregiver or a clinician going in the home is or even as the medical provider in the clinic setting or outpatient setting, it's so important to be able to relate to that human being as a person, and really having that compassion and connection to I don't even know how to describe it, but I know that when I know in advance before I go in a home that there may be some resistance, because a lot of times families will just come right out and say, my loved one does not want care. They're going to be very resistant. And so I do a little extra digging. I'll ask a few extra questions so that when I go in the home, I know the right comment to make. Like maybe I know they love horses, and I'll see horse stuff all over, like hanging on their walls, and books on horses and pictures of horses. And so that'll be something that I will connect with them over. And after I introduce myself or greet them, I'll bring up just something as simple as, wow, I see that you love horses as much as I do, or just a simple connection that it's a personal connection. And that's just one of many examples I can give, but relating to them as a human being versus a patient or an older adult, and making them feel like, you have something in common. And, if they have dementia and have something like that can be a challenging behavior, is that's where you have to know a little bit about them before you're going in, so that it can help you to feel more comfortable yourself. Because if you're anxious and nervous about it, it's definitely going to make them more anxious and agitated. And so the goal is to, or another key point, and then I'll kind of end it there. Is if you can ask a family member what's most important to them. What do they hate doing the most? Like, say it's laundry or changing the bed linens because they have such a hard time getting that fitted sheet on, or whatever it might be. You can make that your big selling point when you walk in, and be like, I know that you really don't want my help, but I would love to be able to get your linen changed on your bed because I know how hard that is for you. And so let me do that, and then we'll sit and chat for a few minutes and just see, you can come take a look, see how I did. And just something simple like that can sometimes just break the ice, and they'll be like, wow, okay, I can do this.
I like that example, Ruth. Yeah, I would just add a few more thoughts to that. I love how you brought up, find out what's important to them. What do they like? Because sometimes we can use their goals of care to help them be more open to having help at home. So, for example, a lot of people, they don't want to stay in the hospital. They want to get back home. And the family can kind of use that goal of getting back home as a way to kind of reframe the conversation. So instead of saying, like, you have to have help at home, you could say, Mom or Dad, I know you want to get home, and there's some things we're going to have to put in place at home in order to make sure that we can safely get you back there and keep you there, because the last thing we would want is for you to go home and then end right back up in the hospital. So here's some things that we're considering. Would you be open to us, adding a grab bar in the shower? would you also be open to having some help at home? It doesn't have to be for forever. It doesn't have to be long term, because sometimes, once you are back at home, you're back in your routine, you're gaining your strength back. You might not need help, for the long term, but could you try it for a while just to make sure that we have the best transition home possible? So sometimes it's reframing it in kind of in line with their goal, and kind of almost make it, really be in support of what they want. So that's one approach that sometimes works. Another opposite approach that sometimes works is the family. We have the sandwich generation. A lot of family members are caring for their aging loved one. They might have children of their own. They might be working, and they might not be able to be there around the clock to help with that transition. So sometimes an alternate approach that can be successful is having the family caregiver say to their older loved one, would you be willing to try this out to help me out? Because I want to be here, but I have to be at work this week, and the kids have their activities, and it would give me peace of mind if you allowed somebody to come in and help you with a few things around the house, and I'll still be here checking in, but that extra help would be more so for me, less for you, just to make sure that you're well taken care of in these, coming months. After we get you home from the hospital. So sometimes it's all about how you phrase or rephrase kind of the notion of having help at home that can maybe help to make it a little more of a receptive conversation and less of that resistant conversation. So hopefully those tips are helpful, and that was a really great question.
Absolutely. Thank you.
Yeah, anything else, Ruth, that you would add?
No, I think you hit a lot of very important points. Thank you.
Absolutely. I know that there's been some questions around kind of the payment aspects. Somebody had said, I didn't know Medicare Advantage covered, home care. And I will just go back and hit on that quickly. Not all Medicare Advantage is covering home care. Medicare Advantage is kind of like dipping their toe into this world of home care. So it's very specific to the person's Medicare Advantage policy. So I don't want you to walk away from this webinar thinking all Medicare Advantage plans cover it. It's very specific to that policy, but it's worth looking into if they have a Medicare Advantage policy. Same with like a long-term care insurance policy. Those are all very specific, written to the individual policy holder. And so even one policy within, for example, Genworth, for one individual might look very different from another individual with also a Genworth policy. So you just have to do a little bit of digging and a little bit of research to just make sure that home care types of services are covered. Let's see, I'm looking through these questions. There's some great reminders, making sure families get the contact information for the care managers or social workers before they leave the hospital, because those individuals can be great resources to tap back into. So I think that is a great tip. And let's see here. Let's talk, lastly, somebody brought up long-distance caregivers. And Ruth, we see this a lot where we have, a client of Homestead and their adult children live long distance. And so that adds another layer kind of complexity to this readmission, kind of returning home conversation. And I think that's where this help at home plays, an extra important role as the eyes and ears in the home for those long distance family members. So Ruth, from your experience, any thoughts on kind of just the benefits of support at home for those long-distance caregivers?
Absolutely. So we see this all the time, pretty frequently, and for a variety of reasons. And there is so much that home care providers can do to support those family members that are so far away or just not available. Of course, every agency is different in what they can and cannot do, but I can speak from experience that majority of the time, the professional caregivers can pick up those prescriptions before the older adult returns home. They can work on helping that client find someone who can install grab bars for them in the right locations. They are part of the care coordination process. So if there's other providers in the home, like home health, they're the eyes and ears and communicators. And I know as the registered nurse on a case, I often help facilitate that and can help find those resources as well, especially in the absence of a family caregiver who we normally would have, spearheading a lot of that before a person returns home. The only thing is a lot of times, you want those things in place before they actually return home. What's helpful is when you already have existing caregivers on a case, they definitely can be a part of doing a lot of those things in absence of a family caregiver.
Wonderful, Ruth. Thank you so much for those insights. And I know we're at the top of the hour. And so, Ruth, I just want to thank you again so much for bringing your expertise to this webinar today. It's been such a pleasure to listen to you and to learn from you. And I want to thank everyone else on the call as well for joining. And now we'll turn it back over to Victoria.
Thank you so much, Lakeland, and thank you, Ruth. It's been such a pleasure having you today, and we want to thank Home Instead for bringing this webinar to our audience. Please be sure to check out upcoming webinars, including Understanding the Legal Needs of Aging on December 6th at www.asaging.org. And as a reminder, please do review the step-by-step CE guidance page to review the process before you submit an application. That is linked in the follow-up emails and also on the left side of your screen under the CE Application Here tab. It's going to take a minimum of 2 hours to be able to access the application while attendance data syncs. But if you have any questions about the webinar, please feel free to email us at info@asaging.org. And you have 60 days to claim any CEs, so please feel free to share this presentation with anyone you know that may be interested. And thank you again, Lakeland. Thank you, Ruth. And thank you, Home Instead. We hope you will all join us again soon. Bye-bye.
Thank you.